So, good evening, everyone. Welcome to our 25th edition of this Powwow. I am Dr. Astha Bansal, a resident here. I would like to invite today's moderator, Dr. Mugundan sir, to take over. Over to you, sir.
Hi, Asta. Thank you so much for the introduction. And hi, everyone. Very warm, good evening, everyone, and a warm welcome to this Powwow session. It gives me great pleasure to extend a heartfelt welcome to our esteemed panelists who need no introduction, Dr. Rama ma'am, Dr. Sudhir sir, and our star alumni, Dr. Rishi Swarup from Swarupai Center, Hyderabad, and Dr. Varsha. It's an absolute privilege to have you all with us today. Welcome once again. Now, now it's my pleasure to introduce our guest speaker of the day, Dr. Ankit Anil Harwani, a dynamic cornea specialist and a passionate academician. Dr. Ankit completed his MBBS from Indira Gandhi Government Medical College, Nagpur, followed by his MS in ophthalmology from the Institute of Ophthalmology, Joseph Eye Hospital, Trichy. He further earned his expertise through a cornea fellowship at our Shankar Nethralaya, Chennai. His academic contributions include several publications in leading journals, as well as an authorship of a chapter in the book published by Springer titled Ketoconus. Currently, he is in private practice at Netra Jyoth Eye Hospital, where he continues to combine his clinical and surgical acumen for his best patient care. Beyond his professional pursuits, Dr. Ankit enjoys music, photography, and reading. So, very warm welcome, Dr. Ankit. We are honored to have you today, and you will be sharing with us the journey of DMEC and along with the practical pearls and insights you have gained through this clinical experience. So, over to you, Dr. Ankit.
Thank you, sir. Thank you for the kind introduction. Good evening, everyone. Thank you. I would like to thank Cornea Department and Shikha ma'am especially for giving me this opportunity. And I can't thank enough to all my mentors, without whom I would not have been able to do and give a talk on DMAC. So to start with a small introduction, DMAC involves transplantation of the donor descemet membrane only, as opposed to DSEC, which involves some portion of the posterior stroma. For this basic reason, the DMAC surgery has less chances of rejection as there is less antigenic load, faster and better visual outcome, and there are less aberrations postoperatively in the cornea. The reason I started doing DMAC early in my private practice was we all know that it is one of the advanced form of corneal transplantation. And the other reason was the region where I am practicing here, not to the best of my knowledge, there are no cornea surgeons who are doing DMAC surgeries. So most of them are doing DSEC. So these two reasons allowed me to gather courage to start my DMAC very early. I have done only 2 DSEC surgeries, out of which 1 had failed. To start with, I had procured a lot of practice eyes. I had used around 20 practice eyes to do the DMAC donor preparation. And this wouldn't have been possible without Disha Ebang, who had supported me a lot. The first challenge that comes is the donor preparation. The first step in this donor preparation is the partial thickness refination of the donor cornea from the endothelial side. The ideal size that needs to be used is 9 to 9.5 millimeter, but initially I had used 10 millimeter trifine just to get a wide margin for error. And eventually I realized the more peripheral you are, it is difficult to separate the descemet membrane from the underlying stroma. So there are 2 kinds of trifines available, the normal trifine, which we use regularly, or the fixed depth trifine. Personally, I have had a very bad experience with the fixed depth trifine in one of my cases. So I don't use it now. I use the normal corneal trifine. The judgment about the partial thickness trifynation, it comes eventually. So for partial thickness refination with endothelial side up, you just do the partial thickness refination with the normal refine, and after you are sure that refination is done, just stain the endothelium to have a better clarity about the refined edge, which will facilitate in the further steps of the preparation. Then comes the DM scoring. The Descemet's membrane scoring is the step in which you have to just separate peripheral one around zero. 0.5 to 1 millimeter of the Descemet's membrane from the stroma. And these both the steps need to be done in the pool of saline to reduce the surface tensions from the DM and the adherence because of the adherence towards the stroma. So to start the DM scoring, you need to have a taper tip instrument. There are instruments which are specifically designed for the purpose. Initially, I have used during the practice sharp choppers, blunt Sinsky hook. The one which I'm using, which is shown in the video, is Mohan Rajan chopper. Obviously, sir must be using this for phacoemulsification surgery, but it has the exact configuration which is required. So you just start separating the Descemet's membrane from the stroma all around 360 degree. Once all the Descemet's membrane around 360 degrees scored, you need to grab a edge with a flat tip forceps and peel the Descemet's membrane along the contour of the cornea. The peeling needs to be done very gently, and while peeling, we have to be sure that the peel edge is forming a straight line, and there are no undue areas of folds or tractions, because those can lead to tear while peeling. So I'll just forward this video. So here in peeling, the direction of force should be towards along the contour of the cornea. If you lift up away from the cornea, it might cause a traction and Descemet's membrane tear. Once 2/3 of the membrane is peeled, you stain the membrane for your further reference, the peel, so that you are able to know where the peel portion is. 2 or 3 millimeter or 2.5 millimeter punch on the bare stroma for marking the Descemet's membrane, and then deposit the peeled area back and remove the fluid with a cotton tip bud. Sometimes during scoring, we might, and I have encountered an area where there are radial tears. In those cases, I just start the scoring from in the opposite direction. Once the scoring is complete in all 360 degree area, once I notice that there is a torn radial tear, I just mark the area on the sclera with the marker pen, so that I know where the tear had occurred. And while peeling, we just have to remember that we need to peel in the exactly opposite end, so that, because if we peel from some other area, so when the peeling edge reaches this area, there are chances of radial extension of this tear centrally. So just flip the donor cornea, remove the punched area, 3 millimeter punched window, completely dry the Descemet's membrane and the undersurface of the punch, so as to avoid smudging of the mark. You have to mark the Descemet's membrane with an asymmetric letter. Once the marking is done, you have to decide the size of the final graft which needs to be taken. I usually measure the white to white diameter on the slit lamp of the patient before the surgery. And usually if white to white is more than 11 or more than 11 millimeter, I take a 8 millimeter graft. If it is less than 11 millimeter, I take a 7.5 millimeter graft. So I have to make sure that marked area is included in the refine. This also is a partial thickness refine. the unwanted peripheral frill is being removed, then we have to grab near the attached portion of the Descemet's membrane and gently peel it as was done previously. Once the Descemet's membrane is peeled, we get the scroll, stay in it for 90 to 120 seconds, and our scroll is ready for insertion in the recipe. This is the case where I had used a fixed depth refine. Without the fear of having a full thickness refine, I had pushed it with all my force. But even after that, when I was trying to remove the peripheral unwanted frill, I realized that the refine was not even started in some of the areas. It just had made a little indentation in most of the areas. So I didn't know what to do. So I had taken a normal refine, tried to match it with the previous refine margin. Obviously, it didn't happen. And then when I started peeling the Descemet's membrane, I realized that the areas where the indentation had occurred because of the first refine, in those areas, the tissue was getting torn, as we can see in this video. So this is the first area where a small crescent of tissue was lost while I was trying to peel the donor scroll. Then I thought maybe it's okay, a small area, I can still get away with the case. Then I started to peel from some other end, but here I was almost about to finish my peeling, but at this point, I think here one more tear had occurred. Then again, then I decided that I cannot go ahead with this case, so I had to abort this procedure. I don't have a liberty of having a backup tissue, so all of my cases, I prepare the donor scroll first, and then when I am sure that the donor scroll is properly prepared, then only I take the recipient inside the OT and start the recipient preparation and then insertion. Then recipient preparation is similar to dissect. We need to remove the epithelium to have a better view of the anterior chamber, remove the epithelium completely. Then I had made the 8 mm mark on the epithelial side to have a guide where I need to start my DM stripping. Then before starting the Descemet's membrane stripping, we, as a rule, we use a sodium hydrogenate viscoelastic, and I always stay in the Descemet's membrane. I do not have a confidence now in stripping the Descemet's membrane under air, so I use viscoelastic agent. The stain allows me to better visualize the Descemet's membrane. So initially with the reverse Sinskey hook along the marked area, just a sort of kind of incision, kind of just tear is made along the marked area. Once tear is made all around, slowly and in a small step, I try to pull all the Descemet's membrane slowly in small step until whole of the Descemet's membrane comes out in total. Hardly I have got the complete Descemet's membrane into total. Most of the time, I have some of the tags remaining inside the anterior chamber stuck to the stroma. Those tags I usually remove with the microforceps or with the anterior vitrector. So once the Descemet's membrane is removed, diseased Descemet's membrane is removed, I check it is spread over the corneal surface to make sure whether it is complete or incomplete. And if it's incomplete, I look for the areas where I could see any Descemet's membrane tag and remove it with, as I said, with the vitrector or the microforceps. I am comfortable with the PI doing with an anterior vitrector. The PI which I have done here is a little large one. this was done in one of my initial cases. Uh, Now I have learned to do a small PI with the anterior retractor. Basically, we use low settings, low cut rate, 100 cut rate per minute, 100 vacuum, and 10 to 15 aspiration rate to get a good PI. PI need to be made inferiorly as a rule. So coming to the DMAC injectors, once recipient preparation is done, there are a lot of DMAC injectors available. The ideal one is the glass cannula. Working in a two-tier city, there are a lot of cost constraints because initially I realized that patients were getting reluctant for surgery because of the cost. So I had to reduce the cost of the surgery, and subsequently I had to look for cheaper and effective alternative for most of the instruments, including the injectors. Online, there are various ideas available for the DMAC injectors. Most of them involved our routine IOL cartridges. The one I am very comfortable with is an Alcon C cartridge because it is readily available in my OT, and the length of the cartridge is good, I feel. It consists of the Alcon C cartridge attached to a 3cc syringe with the cut end of the IV tubing. Most of my cases, I've used that Alcon cartridge until recently. Since previous couple of cases, I've started using this glass cannula. Definitely, it gives you better clarity of the orientation of the graph, the manipulation of the scroll along this wider end allows you to manipulate the scroll into the desired configuration. Also, the other hand is free if required for any manipulation of the patient's eye. So before inserting the graph, we need to make sure that graph is in the proper orientation. The ideal scroll that we should get is a double scroll, but most of my cases, I have got a scroll of, this configuration, which is basically configuration of a dosa that is served in a restaurant. So the ideal right orientation is the one where your bevel of the cannula and open end of the dosa or scroll is facing, is aligned to each other, and both of them should be facing towards the surgeon. So once this orientation is ensured, I proceed for the insertion of the graft. Graft insertion can be done with suture bites taken on the main wound without tying or without suture. And the insertion need to be really slow and gentle. And once your graft is in the AC, I had learned that you have to be very careful while removing the cartridge or the cannula. So this is my first case where I had used the suture. I had taken the bites but didn't tie. I had to remove the thread which was there between the lips, both the lips of the wound outside, so that it does not come in the way of the graft. Once I'm sure that the inner tip of the cannula is inside the anterior chamber, slowly I had pushed the graft while removing out. Still, some of the portion of the edge of the graft was stuck in the wound, but I feel this is okay. You just push the edge inside and tied the wound. In couple of my cases, I had learned that when the anterior chamber is watertight with your wound and cannula, and I try to remove the cannula, suddenly the graft had come out and it was stuck halfway in the wound. In both of my cases, this was very undesired situation, as I was afraid of getting a primary failure. I had removed the graft, reloaded it, and then had re-injected it in the same patient. You can see in this video, I had reloaded the graft. And then while this time I had made sure that the wound is not watertight, I had slightly increased the size of the wound so that there is no watertight, it's not watertight, and there is some leak of the fluid. Also, my AC was not completely filled with the fluid, as we can determine with the folds. And this time while coming out, I had injected some amount of fluid also while coming out in short bursts, so that the graft stays inside the anterior chamber. So coming to the second and the most challenging part of the surgery, I would say, uh, in my initial couple of cases, I had no idea how the scroll behaves inside the anterior chamber. All the videos I I had seen online. Uh, I tried to repeat all those maneuvers, but nothing made any sense. The mistake which I did was I never practiced opening the scroll in practice eyes in artificial anterior chamber. Uh, I believe at that point I was thinking that it will not replicate the exact uh, uh, situation what a normal natural eye will give. So I just went ahead with my first case without even practicing the opening the scroll. I remember I had to spend about 45 minutes to an hour to open that scroll. Ultimately, it opened, but patient later developed cystoid macular edema also, for which I had to manage him. So some of the things still I had to learn how. Still, I'm not sure how. For most of the times, I'm not sure how the graft behaves inside the anterior chamber. But there are a few things which I have learned so far, which I'm going to show in subsequent videos. The first one is how to center a graft. Many videos online they tell you that you have to tap at the limbus to center the graft so that the wave pushes the graft towards the center. But it works sometimes. I don't know why it doesn't work. I'm not sure why about that also. But this is one maneuver which I feel is very helpful in such situations when the graft is at the periphery. You just use two instruments like forceps to just compress the peripheral anterior chamber, and with the other instrument just tap the graft towards the center. As your graft advances towards the center, move both the instruments along with it. And one more thing I realized that if I lift the fixing instrument suddenly, because of the fluid that comes back with the gust, it brings the graft back towards its original position. So this is one thing that I've learned, that while lifting the fixing instrument, we have to lift it in a very slow manner so that the graft doesn't comes back to its original position as shown in the video. Then the most common maneuver, if we get a double scroll, we tap at the center, just like I did in this video. And slowly the graft opens up with the ripple waves that are created inside the anterior chamber. And the yes, if the graft opens, sometimes in the periphery there are small folds which are little reluctant to open. In those cases, if it is near any of the wound, just like I did now, we just have to remove some of the fluid out so that the outcoming fluid opens up the folded edges along with it. A couple of my cases, I had a young donor, about 52 to 53 years of age. Definitely, obviously, we know that we get a tight scroll when the donor is younger in age. So, in such cases, this also is many people are doing this. That we use a air bubble between the graft and the host cornea, and very small air bubble, and just move the air bubble around the folded edges of the graph. And with the tamponade effect, it opens up the donor scroll. Once sure that the graph is in the center and is opened up, just go with a 30 gauge cannula inside the anterior chamber to make sure that the cannula is inside the anterior chamber. We have to look for this bluish discoloration of the cannula, which means that cannula is below the donor scroll. Once the cannula tip has reached towards the center, slowly inject the air, completely fill the anterior chamber with air. We have to do a complete fill. Also, I have sutured this side port also because there was a leak and I was not able to center the graph in this case. So I had to suture. There was a lot of fluid leak from that side port. So if required, I think we can suture both the side ports also if required. These are my initial 8 cases. In the first case, I told you that patient developed cystoid macular edema. After managing that, the patient had the best corrected visual acuity of 612 parts and 8. This is my second case. I don't remember. I think the patient was lost to follow-up, and his vision last seen during last follow-up was 612 and 8. This patient, third patient, I had planned the DSEC because I knew there was a scar which was deep, but I was not sure how deep it was. I had planned DSEC. This case I had not done at my center. I had done in medical college where I am attached. And there was no instruments ready for DMAC. But during DSEC preparation, I had a perforation of the donor graft. When I examined, I felt that I can still get a DMAC donor tissue from that graft. I was fortunately able to get a good 7.5 millimeter DMAC scroll. But after that, when I took the patient, I realized that the opacity was too deep, and though it was inferior, slightly inferior at the pupil, but somehow I was luckily able to open the scroll inside that also. I don't know how I did that, but the patient was uncorrected, 618, and was happy. She was very old party and she didn't want much, so even I was happy after that. And this is my fourth case. This patient had dislocated IOL, which I was able to see preoperatively. But the thing I didn't realize that one of the haptic was in the angle, which I realized after removing the epithelium on the operation table. I had prepared the graft. I could not do anything else. I tried to rotate the haptic slightly so that only the tip is there at the iris, but still it rotated back and most of the haptic came back in the AC at the angle. Patient uncorrected visual acuity was 624. She was not improving further beyond that, but her graph was good. Her cornea was good. There was no edema even after 3 months post-op. The two cases which are marked with the red dots are the cases where my DMAX scroll came out during initial injection. I had to reload it and injected them again. These two patients, edema took a little longer, about a month or month and a half to resolve. But eventually both the graft survived and I couldn't be more happy for that. These two cases are straightforward cases of PBK and they were doing good post-operatively. Thank you.
Oh, so thank you so much, Dr. Ankit, for lucidly sharing your experience as well as showing your struggles. Actually, it was a very video-oriented presentation. Very nice. Thank you so much. So I open the podium for the panelists and for the audience to ask any questions. But I thought I have some few questions. I thought we'll ask the panelists. So starting with Rama ma'am, ma'am, your go-to donor criteria for the DMEC cases.
So I think excellent presentation, Ankit. Really very
Thank you.
lucidly done, and really proud of the way you have transformed into a beautiful DMEC surgeon. I also
Thank
want to
you.
welcome a lot of the alumni who have joined us. Very happy that you're all here today. So, going back to your question, Mukundan, I think for any keratoplasty, be it DSEC, DMEC, LK, PK, there are some criteria that will improve the outcome of your surgeries. So the first thing is, I think, as far as the DMEC goes, it is even more rigid because you're dealing with a very delicate tissue. So the first thing I think is about the age of the donor, because quite often we are told that the donor age should be anywhere between 50 to 65 or 70. And we just take it like that. Why is this? Because in a DMX scroll, I think two things are very important that determines the dexterity of the scroll. One is the thickness of the scroll, and two is the elasticity of the scroll. So what happens with age? There is an increase in thickness of the posterior non-banded layer of desmus membrane. So the graft continues, the cornea continues to thicken, and there is a decrease in elasticity with age. So because the optimum thickness and elasticity is what determines the tightness of the scroll, you get it somewhere between 50 to 65 or 70 years of age. So if the donor is more than that, also people have used it up to 8 years with good results, but the limitation could be that because it is thicker and less elastic, you can have a peripheral scrolling which can make it difficult for you. The corollary to that is if it is a younger donor, then it is very tight. And like Ankit showed in one of his cases, it's more elastic, its separation peeling is difficult, and then it also tends to curl on itself and becomes difficult for you to scroll out. The second thing I think is for any of these keratoplasties, the criteria is about the endothelial count. So you want a good count anywhere between 2000 or 2500 or more. More importantly, with a good morphology, because it's also equally important that you don't just look at the count. If you have the accessibility, you want to make sure that the morphology of the cells are also reasonably good. The third thing is the phakic or the nature of the eyes. I personally still prefer phakic eyes, but I know there are some studies which have said that even pseudophakic donors, because in this time and age, everybody does very good phacos. There is hardly any loss. There's a very limited loss of endothelial cells, neatly done surgery. So maybe pseudophakic eyes are as good donors as phakic eyes. But like I said, my personal choice is a phakic eye. But the other one small limitation in a pseudo phakic eye, if at all you have to use it, is that you may have, whether it is SICS or whether it is phaco, you may have that peripheral area of scarring that may be there that will be adherent, and therefore it makes it difficult for you to score in that area. So that is one thing that you want to keep in mind. The next thing is the duration in the media. I think all of us prefer tissues that have not been in the media for too long. Otherwise, too long means it can tear and you can have issues, and the viability of the endothelium goes away. Last, I think the most important thing is the diabetic status of the donor, because along with the points that I said in terms of thickness and in terms of elasticity, if you have a donor who's also a diabetic, see, our cleavage plane is between the stroma and the desmus membrane, but whichever way you want to peel it, this is tightly adherent with a lot of interfibrillary changes in a diabetic. So the peeling is difficult. This adhesion is more in the center of the cornea. So some people even say, for the diabetic, do you want, if you can do away with a slightly smaller graft, do you want to just decenter so that you minimize the amount of peeling that you have to do in the center? So in a diabetic patient, the tear is definitely a possibility. So we have to be even more gentle. I think this information is important. Other thing is, if you have a tear in a diabetic when you're doing the first eye, Ankit said he doesn't have a spare eye, but some of us do keep a backup eye. I would suggest that we don't use a pair of the same donor, because the peeling characteristics have been described to be very similar in these patients. So if at all you have a spare tissue, and if you can afford a different donor, then I would suggest we take it from a different donor. I think as far as the recipient diabetic status is concerned, there are some issues in terms of rebubbling rates and all that. But I think as far as the donor itself is concerned, these are the things that come to my mind.
Thank you so much, ma'am. I think you have covered all the points. And then regarding surgeon prepared tissue versus already prepared tissue from the eye bank, any difference? Dr. Rishi, you want to add if you have any experience between the surgeon prepared scroll versus eye bank already pre-prepared scroll? Any difference it makes?
Hi, thank you for involving
Yes.
me, and wonderful presentation, Ankit. Really, you covered it very well from the point of view for a beginner. I think you showed a lot of your learning steps and also some of the complications you faced very candidly, and that takes a lot of courage. And I think Dr. Rama covered all the points of the donor very well. Another thing I'd just like to add to that before I come to your point, Dr. Mukundan, is that if it's a pseudophakic donor and if intraoperatively the patient has had some injury to the desmoids, like a small desmoid tear or some touch, sometimes you can have focal adhesions or again tears, which while stripping you may not realize, but you may end up with a tear because of that too. So from that point of view, it's always better to choose a phakic donor if you can for DMEC, but we don't have a choice in private practice often. Coming to your question, Dr. Mugundan, of course, pre-prepared tissue is always better because it saves you a lot of headache. I have not done too many. At LV Prasad, they do provide that now, but it's more expensive. So they strip the peripheral part of the desmoids from the donor, and the central or paracentral area is still attached. And so you can just then intraoperatively take it up and mark it, create a window, mark it, and then you refine it, and then you can essentially do the rest of the steps. So it just saves you some time and reduces your risk of having a tear because they have already done the main bulk of the stripping of the desmoids, and just the final refination and stripping has to be done. So from that point of view, it's definitely better, especially in the early stages when you're learning. I personally just do my own desmoids preparation because I don't struggle with that anymore so much. Of course, once in a while you do have surprises.
Thank you so much, sir. Like you and Dr. Sudesh sir can share the tips. Dr. Ankit has beautifully demonstrated in video also tips for beginners for the donor preparation. If you can share, it will be good.
So I
Ankit,
think,
it was. Yeah, go ahead.
Carry on, Dr. Sudesh. And I'll join after we carry on.
Ankit, your excellent presentation and
Thank you, sir.
really beautiful. You have demonstrated very well how to do the stripping of the donor tissue. Luckily, during my initial stages, I had been to US and I had gone to one of the eye bank, and we had some project there where I could do almost like 15 to 20 donor tissues preparation for one of our endothelial project where we were with Indiana University. And they actually do not even do a punch. They just use the blunt lens like IOL dialing and make a glue all around, and then they keep lifting up. So you can slowly lift up like a dosa, no? You can just in the periphery just lift up and keep going. So that, and wherever you come across some tear, just convert that into a small rexus out of it, so that you have any. And always when you start doing the stripping, you need to identify the position where you are starting and then complete it, because when you start rotating, you don't know whether you are going to go around again and again. So always mark either using some kind of iris pigment in that on the sclera or some point, so that which will help you to go through it. And so to make sure all the periphery, at least you have 1 mm, or sorry, at least 0.5 mm of desmoids is lifted 360 degrees, then you start peeling it. So while peeling, as I said, whenever there are tears, make them into a small rexus and remove them. Even it is little big also, it's fine, because you have good almost 2 mm of tissue where you can really, which is in the periphery, which you are going to throw off at the end. So that is one thing which you need to look at. And as you are stripping it, as you said, you did really very well. So we need to keep eyes on both ends of at the periphery, because in the center it's easy, because most of the tears starts occurring in the periphery. Make sure that is whenever you find there is a resistance, deposit it back and then release any tight additions which are there with the desmoids, and then come back and continue it. So do not continue in a one single strip. Whenever you find the resistance, just deposit it back and then come back. So I think these are few things which really work. And as Dr. Rama said, in case you have a problem with one tissue, do not use the other eye of the same donor, because I had the same thing initially So I had a tear, and that patient had a diabetes. The donor had a diabetes, and I had used the other eye. Again, I had a tear. So that was like really. So it is the lessons which I learned with after burning your fingers. So this is something which you need to keep in mind. Yeah, Rishi, please go ahead.
Yeah, I'll just add a little few points, excellent points, Dr. Sudhir. One is if you're using a punch for your initial bigger trephination, instead of just directly scoring it, you must not punch. You must make sure that sometimes when you punch, you must not rotate. If you rotate, then you can end up tearing the periphery of your desmes, and sometimes you can end up with radial tears because of that. So just punch vertically without rotating. This is especially when you're using a free handheld refine. You know, we have a habit of rotating a little bit for our penetrating keratoplasties, etc. So here you should not be doing that. Second thing is, after you've punched, it's a good idea to just put a little bit of your trypan blue and mark the area where you punched. The edge becomes stained. So what happens is it will tell you which area is also separated from the stroma. So some areas will already be separated, and those areas will stain on the underside, and that will give you a good place to start your dissection instead of just starting at the edge, because very often when you punch, the edge gets tucked in a little bit into the groove. So you want to just bring that edge back up. So first, good idea is, even if you're using a sharp instrument, just make sure you just insinuate it under the edge of the desmes where it's separated, and then go all around and separate it, not just open up the groove, but also lift up the edge. And then you basically grasp with any non-toothed instrument. Like I use a suture tie, fine tie, and then, like you said, peel very gently. Keep an eye on the line where the desmes is separating from the Duas layer. And anytime you see a kink, stop, and then you change the direction of pull and come back to the area where it was adhered in the end. So those small steps if you follow, and at all times there should be enough fluid. It should not be on a dry kind of a bed. It should be submerged in fluid while you're doing the dissection. And after, like you said, after you've done about 2/3, you can stain the part that you pre-dissected, so that later when you're going for your rest of your dissection, you know which part is already separated after your second trephination.
Thank you, sir. Any point, Varsha, you want to add? RR ma'am or Varsha, any other points you want to add?
Excellent presentation, Dr. Ankit. I think beautiful videos that you showed. Sometimes what helps me is that because we use guarded punch, I gently tap 360 degrees. So that tapping will give you, with the pool of the saline, that tapping actually at places, it helps in the separation. And even if you get 1 point of where you can actually nudge your scorer or any instrument that you are using, even if you get 1 point, then you just, what I do is that if there is a partial indentation mark also, and if it is not separate also, I just rotate the donor rather than rotating my hand, and it just comes off beautifully. So like tapping helps me. And if you do not get a plane of separation with this pointed end of the scorer, or with any kind of, like I have used side port also to make just horizontal peripheral nicks, and then under that you can go and put your scorer, and then you can start your scoring. So I think that works for me. I'm not sure how, but yeah.
So the one point that I would like to make is, I think all points have beautifully been demonstrated. After making it, when you're trying to make the scoring, I'd like to do a 360 degrees, just to see if I have caused a little bit of separation, rather than, starting to peel and then finding some areas are stuck. I do the same in my femtoelastic flap also. I score the edge and then only I separate. So like that, I think I like to score the edge a little bit, so that I'm reasonably sure that there are no tight additions, and if there are any, I'd like to separate them before I go ahead with the separation. Rishi, I just want to ask you one question. If you have a tear, say that's not in the periphery. We have come to the mid periphery and you have a tear. I know there are different scenarios, but grossly, how do you approach it?
Ma'am, if it's a small tear, I'll just ignore it and go around it and basically complete the dissection of the donor from the other sides. And we'll continue with the DMEC as a DMEC with a small perf there. And hopefully that shouldn't matter in the end. But if it's very large, then sometimes it can cause a problem. You want to make sure that it opens up in the correct way finally when you put it in the eye. If it's a large tear, what I will try and do is I will try to trifine the final trifiniation eccentrically so that a bulk of that tear is in the periphery, and then maybe only an edge is there. And that also then in the end, I can try and kind of convert it into, you like a small excess, you make it a D so that it won't extend further during the manipulations in the eye.
Right. Yeah. Thank you.
Yeah.
Okay. Thank you so much. And we'll move on to the next question. Like other doubt I had is like for the recipient preparation, like for the size trephination, any size we prefer based on the white to white, like DSEC sometimes 3 mm less than the white to white. For DMEC, should we do the complete peripheral scoring or we take 1 to 2 mm less than the white to white for the recipient DM scoring?
I just
Dr.
take
Rishi wanted it.
I take exactly the same size as the donor. So if I'm doing 8, I'll just mark 8 and take that off. I don't really oversize it.
Because if there is a decentered graft, that doesn't make a problem. Like there'll be a difficulty in the adhesion if the DM is not big.
I guess you could oversize by 0.5, but I don't think you need to go all the way to the periphery, because if you do that, sometimes you'll get these peripheral bullae and that makes the patient quite uncomfortable. So I don't do like a limbus to limbus scoring. I just do a little larger than the graft.
If I can say something, I think as a part of your cursory examination, whether it's PK or DSEC or DMEC, it's important to have a gross idea about the corneal diameter because it does help. Even in DSEC, you don't want, if it's a microcornea, say, let's say, slightly lesser corneal diameters, you don't really want to go limbus to limbus, then you can have crowding of the anterior chamber and other problems. One instance where you might want to oversize a little bit if your corneal diameter is all right could be a PBK as against a Fuchs where you have a good peripheral reserve of endothelium, I would think.
So regarding the injector thing, Dr. Ankit has showed he has used the Alcon B cartridge also, and now then he's gone promoted to Guda's glass cartridge. So like any preferred cartridge or anything for the beginners to start with?
I think glass is always better. Endothelium is precious and glass cartridges are now quite cheaply available in India. Also, we have Joja Surgicals and others who are making them, and they're not expensive at all. So I would suggest better to just invest in a glass cartridge because they're not too expensive and they will definitely be better than the IOL cartridges, what I feel. Of course, if you're used to an IOL cartridge and you feel more comfortable with that technique wise, then sure enough. But otherwise, I personally prefer the glass cartridges.
Dr. Sudhi sir, anything you else want to add, or RR ma'am or Varsha, anything else for the injector?
Luckily, we were using glass cartridge from the day one, so I do not have any experience with the cartridge. Yeah.
Now, how to handle the tight scroll? Like Ankit has showed some examples also, like regarding with use of hair bubble and double tap, everything. So, Dr. Swarup, how do you handle the tight scroll?
If I have a donor less than 45, I don't do DMEC. I just use it for PTEC. So I've never really had a tight scroll, to be very honest. Yeah.
And anyone else wants to add? Sudhi sir, Varsha, like how to handle
so there are cannulas that are available. I myself haven't used them, but there are cannulas available. I think it's designed by Dr. Fogla, which has 2 holes on the sides. So you're supposed to put it inside the tight scroll, which is called the cigar scroll. And then you just basically give a short burst of fluid. It just opens up. And then, and then you can continue with all the maneuvers. So I think one thing I'd like to add, Ankit, great presentation, and you made some nice diagrams showing how to tap, etc. If you haven't seen, or if anybody else here is interested, there's a very nice website called patientready.org. It is by this person called Dr. Peter Weldman, and he has very nice animations and drawings of different folds, different formations that the DMX scroll can take, like origami, etc., etc. And for each formation, he has given stepwise tapping maneuvers that you can follow to open the scroll, with also attached videos for each particular formation. So I would strongly urge everybody to go to that website. It's really a very good website, especially when you're beginning stages, when you're trying to unfold the scroll.
Yeah, it's really very good. Actually, when I was starting out, because when you begin, it's very difficult, like where to tap and how exactly it's working. So when I was doing my anterior chamber opening up, I had looked at all his videos, and it's like scientific. It's logic to it. Like, okay, when you're tapping at a center or where you should tap and how it actually works. So it's great.
Yeah, another thing I'd like to add, Ankit, you showed all the taps very well, but one important thing to use is the side ports. So you can actually use the egress of fluid also to unfold your scroll. And I use that a lot actually. So depending on where your scroll is folded up, you can use the side port, or sometimes even the main port I gently depress, and that fluid that comes out will open up your fold as well. So that's another thing which you can use. And another thing is tap and release. That also can open up your scroll edge. So just tap and release, tap and release. So these and then you have the Dirisama maneuver, in which if you have one edge which is folded up and one is open, you hold it down at the open end, and then you just keep tapping parallel to that, and then it kind of unscrolls open. So there are lots of different small maneuvers, and many of these videos actually you can see on that side.
I have one question.
One point, sorry.
Yeah.
Okay. When I was starting out, it's always talked about that, okay, you should egress the fluid, but later on understand that you should have some fluid in the anterior chamber also to egress.
Yes.
So
yes.
If it's like completely shallow, you actually need to push in some saline initially. Deepen it a little bit, and then otherwise it was like, okay, egress, but okay, that nothing is coming out actually. So if you feel
of course
there's no fluid inside, then you should.
Then you can't do that, obviously.
Yeah, then you cannot. The egress function doesn't work. So you put in some saline, and then you egress it out from the side port. So I had a difficulty in understanding initially that part. So I just wanted to make that for the beginners.
Can I add a comment, Mukundan? So I think this technique of decompression is very important, but it should be done carefully, because if you're a beginner and your scroll is just inside, and if you use the main port, use limited fluid, it will not come out. But if you're decompressing and you're using not the right amount of saline, then sometimes with the main port, if you have not sutured it yet, then the graft can come out. So be very careful when you're doing this. And I think same thing about case selection also. Initially, you want to choose cases where there is some visibility, where you'll be able to manipulate the graft. Then you're not choosing eyes with a too large or too small and too shallow anterior chambers. I think these make it more difficult for you.
In fact, shallow anterior, too shallow is also a problem, and too deep is also a problem. So if you have an AFib, post trabeculectomy, which is likely to be, or post vitrectomized patients with tubes, all these are very difficult cases. And of course, if you have any damage to the iris, or if you've got very large PI, cynic K, all these cases are going to be a little difficult in the initial stages. So yeah.
So the other difficulty I used to face is the fibrin formation. Sometimes there is a lot of fibrin formed, which prevents the scroll to unscroll or gets this thing. Any tips to handle the fibrin, or anything in the solution we can add to avoid fibrin? Any suggestion on that?
So fibrin will come if you have touched the iris usually, otherwise it won't come. So or if blood clot, whatever, both will behave similarly. So if that's happening, then you just put for some, and if you have not already put in your scroll yet, just put in a large bubble of air and leave it for some time till everything stops. And then you kind of, after that, introduce your scroll and then do the rest. But if your graft is already inside, then it's a little bit of a challenge. Then you just need to wait, maybe put in some saline, pressurize the eye, wait for a bit till everything settles down, and then continue with your case.
Any heparin solution, anything they mix
Like there have been reports of using enoxaparin in the basis
heparin.
solution. So anybody like has experience of doing
Experience.
that, or like because
I've never used it.
you never used because you did not have a problem with the 15 order.
No, I don't even have access to it. I mean, I've never really kept it in my OT. So, also, of course, we've all had gone through the learning curve. We've had situations like that, but I've not really used it.
Sir, did you have it like when we are making an incision? I know that most of the surgeons make a clear corneal incision, but sometimes there is so much of corneal vascularization also that your main wound, the tunnel wound, also bleeds sometimes, and that leads to trickling of the blood inside. That can cause a little bit of fibrin. So like initially 1 or 2 cases that I had, I just wait for that bleeding to actually stop. It's a little impatient to do that. Or probably you make your entry wound a little before 10 minutes, before you're scoring. So initially I used to score, prepare everything, keep ready, and then I used to make an entry wound, and then it used to take like another 10 minutes for me to have the bleeding to stop. So I think bleeding from that main wound, sometimes that trickles in, also causes a little bit of fibrin. And probably after doing a PI, a good air tamponade till you are taking your graft and getting ready. Just keep in air for that 2-3 minutes, 5 minutes. That also helps for fibrin to not form on the later stages.
So I think a good sequence to follow is make your wound side ports, then do your PI, put in whatever cohesive viscoelastic, do your PI first, and then do the scoring. So by the time all the blood from your wound and your PI, everything would have stopped. Plus, Helon being there will prevent blood from coming out or going into the AC. So that's one of the reasons I prefer to do it under Helon rather than air.
Mukundan, can I make a point?
Yes, ma'am. Yes, ma'am.
So I think this thing about waiting for the bleeding to stop is very important, whatever be the sequence, because if you're a little impatient there, then sometimes surgery takes a long time, the graft gets stained with blood, and it's really a problem. Another important step not relating to this is your paracentesis. I think whichever surgery, DSEC or DMEC, the size of the paracentesis should be just enough for your cannula to go inside. You should not be struggling with the cannula. It should not be too large because air will escape. It should not be too tight because when you're trying to inject the air, you will not be able to enter. So you be careful that you just put it of the right size so that maneuvering is not difficult. At the same time, it's not too large for air to escape. If it is escaping, I think it's very important that you suture the paracentesis like how Ankit showed in one of his cases.
There are a lot to discuss, but we are 8. Might be one final question. Like in young patients, phakic patients, like around 40, mostly FECD cases, whether it's DMEC alone or triple surgery, DMEC plus cataract surgery. Like this controversy. If I feel it's a clear lens, but the patient had landed in 6 months or 1 year with cataract. So whether a plain DMEC alone or it's a triple surgery. Dr. Swaroop or Dr. RR ma'am, your thoughts?
If it's 40, I would be okay to go ahead with just DMEC. But if it's late 40s, certainly would consider a triple procedure. The advantage of a phakic eye is that the AC is little shallow, so unscrolling of your DMEC scroll is actually easier. Yeah.
So I think same thought process. I agree with what Rishi is saying. Little older patients where you think the beyond 50 early lens changes, then you may still want to combine the two. Otherwise, younger patient, reasonably clear lens, sequential surgery is always better.
Also, doing a phaco in a DMEC is actually probably a little safer and easier than doing post-DSEC. The edge of the graft doesn't really detach, and it almost behaves like a virgin cornea.
So what would be the interval that you would wait? Like if you want to stage your procedure, do a DMEC first, and then if there is a need to do a cataract surgery, like how long will you wait before doing the cataract surgery? 6 months, 1 year? Like, is there any protocol?
Yeah, at least 6 months, I think. Maybe even a year, if you can.
Most of the refractive stabilization happens in almost 6 months. So I think 6 months is a good time if you want to really plan the cataract, if you can't really wait. Mukundan, you want to ask if there are any alumni, if there are any questions?
Yeah, ma'am, please. There are no. Yeah. If any other questions, there are no questions in the chat box.
Okay.
Anyone else wants to ask any
I'd
questions?
like to ask the others if anybody's putting these patients on ROCK inhibitors post-op. I'm doing that.
And in a patient,
Almost most of my DMEC patients, I put ROCK inhibitors as well.
I have done in
For
2
how long
cases.
we do that, Rishi? For how long is this ROCK inhibitor?
I put them for at least 3 to 6 months, Dr. Rama, because from whatever it may help, especially for the peripheral cornea where it's not covered, it may help hopefully with some regeneration of endothelium in that area and maybe a quicker recovery of the edema as well.
Okay. I'm not doing
Dr.
that. Maybe we
Amrita
can
Singh
try.
has raised her hand. Dr. Amrita, can you ask a question? Yeah.
Hi, very nice presentation, Dr. Ankit. I wish to say hello to Rama ma'am, Rishi sir, RRS sir. Hi, Varsha. Hi, Dr. Mugundan.
Hi, I'm
Hi.
Amrita.
Hi.
Nice to see you.
Nice to
Yes,
see you.
ma'am. Very nice to see you, all of you. So my question, Dr. Ankit, you showed one maneuver where you injected air bubble to unfold the DM scroll. So after you are done with it, so how do you remove the air bubble? Do you
With
go into the
this,
cannula and aspirate it, or is there any other way?
yes, with the cannula, 30 gauge cannula only because the space is little less over there. You need to go with the 30 gauge cannula, inject the air, and then when you are done, go with the same cannula. Probably use a 1 cc syringe because using a 2 or 3 cc syringe will cause sudden injection or sudden aspiration of too much of air or aqueous also along with it. So I usually do it with the 1 cc syringe because I have more control of air injection and aspiration with that. And definitely use a 30 gauge cannula.
And you go from the side port or main port?
Side port. Wherever, usually the side ports, not the main port. From main port also we can go, but because we have sutured, there is less risk of graft coming towards the wound and getting stuck in it, but preferably side port.
Can I just add one point? Since we're talking about air, I saw Dr. Ankit, you were talking about the air injection behind you, put the cannula in the center. When you're putting the air, it's a good idea to first put a small bubble of air and then slowly enlarge it. If you put suddenly a large bubble, sometimes it can just push the graft to the side.
That was by accident.
Yes. So
I
first put
actually
a small
accidentally
bubble and
pushed
then
a
slowly enlarge it. Yeah.
Is there any other question anyone else want to ask?
Rishi sir, can I ask you a question?
Sure.
To begin with, like if you are beginning with a DMEC, does donor size 7.5 versus 8 matter in unfolding? Like, do you feel that it should be 7.5 or it is 8? Like a larger graft unfolding is a little centration unfolding that's a little difficult. So, what is an optimum graft size if you are beginning out? Like, does it really?
I don't think 7.5 or 8 will behave very differently. I think it should be okay with either. But yeah, it may be reasonable to start with a smaller size like 7.5 and then move to 8. Yeah.
My first graft was 8 millimeter graft. So one of the reason which I think it took about 45 minutes to open and maneuvering also was new to me. So I am also of the opinion that initially to start with, we should start with 7.5 millimeter graft.
Because sometimes it becomes difficult to,
It overlaps with your wounds also.
Yeah, it overlaps and the periphery always has a fold. So even like I feel that if you're beginning with 7.5 is a good size to begin with.
Yeah. Also, in the sizing of the graft, some of these Fuchs cases, they have just central edema and the peripheral cornea is pretty decent.
Yeah.
In such cases, you can actually go for a smaller graft.
Smaller size.
Right.
Yeah.
Even scoring, like we should not be over enthusiastically scoring the peripheral part because it will have some residual endothelial
good endothelial.
Yes.
Yeah.
So
I've done one. Sorry, ma'am. Please continue. I'll just make one point. I had one patient right in the beginning when I was doing DMEC. I forgot to actually remove the donor desmids. And I directly put the DMEC graft in. Everything else was perfect except I forgot to actually score and remove the donor. And actually, that patient did phenomenally well. She was absolutely clear from day one. So, yeah. There is risk of graft detachments, and you need requirement for rebubbling is more in non-stripping DMEX, which has been described actually, which I went back and looked after my case. But luckily in my case, I didn't have a problem.
Also, sir, like if you have a peripheral small detachments on the initial 1 week, like when is it like you will intervene for the rebubbling in such cases? Central obviously will go in immediately and rebubble, but if you have focal, peripheral, or if you have some areas of overriding, if your graft is slightly decenter and if you have overriding with your host DM, so like you will wait, observe, or you will just intervene immediately.
Definitely only observe, because most of these will actually reattach on their own. Overriding, though, I'll definitely not do anything because it's not detached.
Correct.
Only if there's a detachment, you're a little worried. And most of the small detachments will attach on their own. It's only if it's in the visual axis or if it's a larger detachment that you need to intervene immediately.
Rishi, I have one question for you. So
Yes,
in DMEC in Fuchs versus PBK, where the interface is likely to be a little bit not so smooth as in Fuchs patients, do you see the rate of graft dislocation or whatever more in Fuchs in your practice, or is there something you do about it compared to PBK DMEX?
To be very honest, I've not really looked at that, ma'am. But cursorily, I think I've had better outcomes in Fuchs when I just think back. But I'm not sure of the correct answer in my practice.
Thank you.
So one thing which I've noticed in cases of PBK when compared to Fuchs, when there is a scarring and the curvature is a little abnormal, there is a difficulty in the attachment. Even the area of the scar, there was not proper attachment. Rest of the area, it was well attached. That's what I have noticed. In Fuchs, when there is less scarring, the chance of the detachment or that interface fluid was very less when compared to the PBK cases, which I have seen in few cases. Any other questions from anyone? I think we can ask more questions, but it is almost time. We are almost 10 minutes ahead. So thank you so much, Dr. Ankit, and thank you so much
Thank
all
you.
the panelists
Thank
for
you, ma'am.
joining. I invite Dr. Mona for the conclusion. Dr. Mona?
Thank you.
Hi, hello everyone. That was an excellent discussion on the challenges of dealing with a delicate scroll, which often, as I saw, has a mind of its own while doing DMEC. So there were excellent videos which were presented by Dr. Ankit, and practical trips from the vast experience by great surgeons like Dr. R.R. Ma'am, Dr. Rishi, and Dr. RRS. So what I concluded from all your discussion, I'll just quickly summarize it. So beginners need to have a good case selection to go for the Goldilocks, the right size and right anterior chamber depth. Avoid shallow ACs, blebs, traps, sineke in the beginning, and tap the AC in various waves, either center or with two instruments, and multiple ways using the dynamics to unroll the scroll. And compression, decompression, sudden should be avoided. And basically, it's a matter of fluidics, and you can know all the moves from this website, which Dr. Rishi recommended. That was patientready.org, which shows you all the moves. And the selection of donor is very important. As Dr. RR said, it should be 50 to 65-year-old, appropriate thickness, appropriate elasticity, and should be because in older there's a peripheral scroll, whereas in young there's a tight scroll. Good endothelial count as well as morphology. Phakic eyes are preferred. Diabetics are avoided, and always have a backup of a different patient. So a surgeon prepared scroll is better, and good to use a glass injector, which is available. Whenever you have tears, you can convert them to rexes, but avoid having large tears, and avoid rotating the punch. Trypan blue can help in staining. Dr. Sudhir told a very interesting dosa technique, which he has tried. And as Dr. Varsha said, tapping helps in separation. First to do 360-degree scoring and then separation. And a smaller size graft is preferred for beginners. whenever there are scars like in PBK, the attachment may not be great in that area. There may be fluid. And in case you need to do a sequential surgery, a difference of at least 6 months to a year is preferred. And ROCK inhibitors can also be given post-op for 6 months. And make adequate size side ports, not too big. And any bleeding, just wait a little and let it stop. Otherwise, fibrin will interfere with unrolling of the scroll. So that was my take home from all your discussion. Hopefully, I covered it all.
That was amazing.
Fantastic. Huh?
What
She's
a
a glaucoma
great summary.
I know, she's a
Great.
glaucoma surgeon. Looks like we have a cornea person making a glaucoma surgeon. Fantastic,
Really fabulous.
excellent. I want to thank Ankit. I want to especially thank Rishi for being here and spending and giving
Thank
us
you,
a
ma'am.
beautiful
Thanks for the
insights.
opportunity.
Always a
Thank
pleasure
you.
to have
Thank you,
Rishi.
everyone.
Thanks, everyone.
Thank
Thanks,
you, everyone, for the
Mukundan.
Thanks.
opportunity.
Good night.
Thank you.
Yeah,
Thank you.
bye.
Thank
See you in the
Thank
next
you.
powwow.
Bye-bye.
Yeah, see you.
Bye.
Bye. Thanks. Bye.